Hi, I'm Amy Reyes. In this week's News Roundup from Rheumatology Network, we led the week with three stories on COVID-19 and rheumatic disease that were based on new reports published in the Lancet Rheumatology. The first was an observational study that found elevated levels of inflammatory markers, C-reactive protein, and ferritin may suggest which patients will experience a more severe case of COVID-19. In the second, which was a small study from China, researchers suggested that patients with an autoimmune rheumatic disease might be more susceptible to COVID-19 infections. A larger analysis would be needed to support those findings, they wrote. In the third Lancet study, researchers reported that the long-term use of hydroxychloroquine may increase mortality risk, but the risk doesn't apply to patients who use the drug for a short period of time, they found. And in non-COVID-19 news, we featured a study about gout. In this case, researchers published a review and meta-analysis in the Journal of Human Nutrition and Dietetics that finds consuming sugar-sweetened beverages is significantly associated with gout flares. We also featured two osteoporosis studies. In one, atypical bone fractures appear to be more common in patients who use bisphosphonates long-term. Otherwise, the risk is typically very low, researchers reported. And in the second study, researchers found that bisphosphonates lower fracture risk, but not mortality risk, which rises after a serious fracture. And finally, in today's one-on-one interview, we talk with Dr. Jeffrey Curtis. He is a rheumatologist, an epidemiologist, and the Associate Director of the University of Alabama Center for Education and Research on Therapeutics and Musculoskeletal Diseases. This week, he and I spoke about the use of activity trackers as a tool to record and track arthritic flare-ups. The device has been found to be useful in improving patient care, or as Dr. Curtis says, we need to right-size care by giving patients the right care at the right time. In this interview, he explains how an activity tracker can make such a huge difference in the care patients receive. But what we wanted to do today was talk about your recent study that employed the use of activity trackers and working with, I believe it was gout patients. And the purpose of the trial was to possibly test this in some capacity to use it in clinical trials research to track whether or not gout patients are getting their physical exercise. Am I understanding that correctly?
It transcends that. The notion was to understand whether a passive activity tracker device that happened to be a Fitbit could be useful for monitoring people with inflammatory arthritis in the real world and, more importantly, maybe between office visits.
Mm-hmm.
So rheumatologists often lack ways to know really how their patients are doing between the times that they may come see us several times a year. So the notion that I might have a way to help you know how you're doing between the times that you come and see me in the clinic is incredibly powerful. So that's the general concept. And while that certainly could be coupled to clinical trials, and the reason that that would be important would be that tracking a flare of arthritis is a difficult thing to do in a trial setting. People aren't going to always come in when they have a flare, and people's flares will not always necessarily coincide when they have a clinical study visit as part of a research study. But maybe more importantly, as a practicing clinician, I'm excited about the ability to actually know how patients are doing between study visits or in-office, regular, routine, standard of care visits. That's the power here, and that's really the opportunity that is provided by the ability to have both an app as well as a passive sensor device that, in this case, you wear on your wrist, helping your doctor know how you're doing between the time you see him or her.
So why is that important in doing a patient history or a check-in with a visit with a patient? Wouldn't you ask them, did you record your physical activity? What kind of physical activity did you do?
Sure. The patient's word is incredibly valuable. The problem is that you're not in my office every day. Some people may not come into clinic because they say I'm feeling too ill, or I'm having a flare, or I'm sick, or I couldn't drive because my arthritis is flaring. Not much different than you say, well, when I took my car to the mechanic, it quit making the bad noise. Well, I've heard that same kind of sentiment from patients who say, my arthritis was too bad, it was too flaring, I couldn't drive, I couldn't get in to see you. So because people aren't going to come into clinic every single time that they might need help, then the ability to monitor how people are doing out of an office setting when they're at home, just naturally free living, that's incredibly valuable. Most rheumatologists will only see patients with gout or rheumatoid or psoriatic arthritis, 3, 4, 5, 6 times a year at the most. I want to know what's going on the other 360 days of the year that they're living life, because I'm their doctor and I'm their doctor every day of the year, but I need to know what's going on. So sure, you're not in my office every day. That gives me the ability to monitor. But the other thing is that even if you're in my office, say every 3 or 4 months, that's only a few times a year. Do we really think that people remember how they were doing a month ago, 2 months ago, 3 months ago? How long did your flare last? Was it really severe? I don't know. You don't know. I mean, that was 2 or 3 months ago in my example. So the problem being that, sure, I absolutely believe what you say, but recall bias, the problem where, you do your best to remember what things were like, but if too long elapses, if it's more than probably a month or so, neither I nor any other patient is going to be able to as accurately tell their doctor how they're doing, how they're feeling as in the moment. And so the ability to couple an app that lives in your pocket or your purse along with a device that you wear, that can capture in the moment and give me the best 360-degree view of what's going on at any given moment to help take care of you. The last thing that I would mention that's incredibly valuable is the notion that you don't necessarily have to wait until your next doctor visit, which again may be in a couple months, before I might be able to help. So if you're having a severe enough flare, maybe you call the office. We've done online studies of arthritis patients, and while it's common that arthritis patients will contact their rheumatologist if they're having a flare, that may only happen, say, half the time. It's very common that patients self-manage. They're at home, they have some extra prednisone or other steroids, they have some NSAIDs, or they just tough it out and they don't want to bother the doctor, they can't get a hold of the doctor, whatever. But with the ability to monitor via an app and a passive sensor device like the Fitbit, your doctor could call you, because as long as you're comfortable sharing with your doctor how you're doing, I think most people would be for obvious reasons, then in fact that digital data stream coming from the Fitbit, coming from your smartphone app, in fact can feed back into your doctor's electronic health record. Your doctor can either look at him or herself, or part of some of the office staff has the ability to look at data visualization tools to actually know how well their patients are doing. This is the idea of population management, that we as clinicians are responsible for a group of people that we want doing well, not just the person sitting in front of us during an office visit. It's really providing care all around the clock for people even aren't right in front of our faces, with out of office data collected through an activity tracker or through an app. I now would have the ability to actually help monitor how well you're doing, that I could proactively reach out to you if it looks like things have changed a lot, you're having a flare, suddenly your mobility has gotten a whole lot worse than usual. So this idea of out of office care and monitoring people, not just when they're seeking help a few times a year, is an incredibly powerful thing, especially in the era of COVID, where people don't want to come in. And yet I think both doctors and patients recognize the need to be able to check in with your physician. And while telehealth fills a very important role, this provides additional objective, frequently sampled data to augment that care that's delivered at a distance.
Mhm. Is that technology available today to be able to connect the data that you get from a physical activity tracker like a Fitbit to your existing technology, the technology you use in your office? Is that even possible today?
It is possible, and in fact, we're doing it. So the activity trackers that we've been using in this study, we used a Fitbit. We've done other studies where we're using that, or Apple Watches, or we've used Garmin devices. Those are obviously commercial grade devices. You can get an electronic store, you can buy off Amazon or other retailers. So the technology to capture the data is certainly there. We coupled this to the Arthritis Power Registry app. So far, 28,000 people have downloaded that. It costs nothing. It's supported by a nonprofit foundation, PCORI, which is one of the national foundations that's supported with tax dollars that supports comparative effectiveness research. So the app certainly is available at no cost. And then the more difficult piece is integration with the doctor's electronic health record. But in the year 2020, that's actually not a technical problem. That's more of a willingness problem and a governance problem about whether EHR vendors and their doctors are interested to provide that connectivity. So we currently have a pilot project where, yes, we are directly connecting this back into the EHR. So this isn't a theoretical capacity, this is actually being done. And in fact, on the other side of the equation, some of the integration that we have done with one large vendor, NextGen, allows the doctor to prescribe what kind of digital data that she or he wants from each patient between visits. So much like you would order a lab test, say for monitoring of a medication, where you might say, you know, I want this blood test every 2 months, and you would provide an order for that. You can literally write an order for what data you might like from a smartphone app or from a health tracker device and how often you'd like to see it. And then that essentially sends a notification to the app. The app configures itself based on what the doctor asked for, what she or he wanted for this individual patient, and then that's the data that flows back to him or her directly into the EHR. So the technology has existed to do this for quite some time. It's more a interoperability issue, but that problem is solved. Now, the interesting thing about that, though, is not all doctors necessarily are willing or frankly interested or are skeptical about, do I even want to know how my patient is doing between visits? That's probably not something that we should assume. That's why it's very important that we have to be incredibly efficient to not give clinicians or their office staff data that they don't want. We want to give them data that's useful, data that's actionable in real time. You know, show me how this will take care of my patients in the moment. Otherwise, it's just going to slow me down. I'm not interested. You know, not all information is helpful. It's certainly not desirable, particularly if I'm going to waste a lot of time sifting through it to figure out what here, if anything, is important. So we are very respectful of not giving doctors or their office staff information that they don't really want, that they're not going to find useful. And that's where we are only providing back to the doctor the information that he or she has asked for. I think in the future, and as an extension of our work, building machine learning algorithms with artificial intelligence to actually sift through not just, you know, what's changed, but what's changed in a meaningfully important way for this patient. That actually is a current source of our ongoing work, is to figure out how this person's pattern, as we observe in the data, what that looks like under normal conditions when things are fine, and then what it looks like when there may be a problem and maybe an intervention is needed where, at a minimum, the office staff might reach out to the patient and say, hey, it looks like your sleep has changed a lot, your pain levels have gone up, your activity has really gone down a lot, what's going on, and to talk through that.
Well, it sounds like an amazing technology. I would love to be able to have a physician or nurse practitioner follow up with me in that capacity. But it sounds like a lot of work in terms of staffing. Is this, do you think it's realistic given the shortage, you know, that we have in healthcare now and the demands of time of physicians and your staff? Does it require more time?
It really shouldn't require more time. Again, under the condition that I set forth, which really is, in my mind, a requirement. I'm going to only show you things that are important.
Mm-hmm.
Practically what that means is probably 98% of the time, you don't need to see the data in real time. So if I only show you, say, the 1 or 2% of instances where the data reflects enough of a change for this individual patient that I'm going to call it to your attention, then I'm going to only present you the things that are valuable. Mm-hmm. Now, and so that's the key, is not showing everybody everything all the time, because otherwise I completely agree. The time requirements would be so incredibly burdensome. No clinician, including myself, is going to want that. But if I can sift through that using an automated algorithm to filter out the things that you don't want to see, I don't want to see, they're just not that important for this patient's care, because it's business as usual. Everything is fine. It's about the same. I'm not going to show you those things. I'm going to only show you maybe the 1 or 2% of things that are important where, Mrs. Smith, the patient who's participating in this, she's really had a change in her health. I'm going to show you the important things. And that's where any incremental time, if there is much, is going to be pretty tiny, and it's just going to be salient to this patient's care.
Now, patient outcomes. Have you been able to assess how how effective this is in improving patient outcomes, as opposed to managing patients prior to the use of this technology, before and after?
That's a great question. So one of the purposes of the gout study is to figure out, did people's activity, did their mobility or their actigraphy just being the motion or the activity levels that people have, in free living environments, did that change when they had a gout flare? So we found that that the step count each day of somebody experiencing a gout flare was decreased by about 850 steps compared to their usual. So the first step in doing what we've been talking about, this idea of virtual healthcare or virtual rheumatology care, is to make sure that the things that you're measuring are in fact correlated highly with the things that you think you're measuring. So in this case, we think we're measuring, or we'd like to be measuring, an arthritis flare. And in fact, we found that the step count as measured by the Fitbit devices were able to reasonably accurately correlate with that. The next step is very much what you described. Let's now show that with this data, we can improve patient outcomes. So that's definitely a near-term forward-looking direction to show that with this real-time monitoring that we can improve outcomes. This first step of the paper that was just published was saying, let's make sure we can measure the thing that we're measuring with good validity and that it correlates with the clinical event, in this case, a gout flare, that we're interested in tracking, and indeed it did.
Okay. Would you like to leave us with any final thoughts?
So I think the final thought that I might have is although we framed this in the context of a research study, the end goal of this is not just to do clinical research or to support clinical trials. It's really to enable rheumatologists and rheumatology clinicians to take better care of patients. You mentioned that there's a workforce shortage. There absolutely is. So what that means is that we can't keep doing the same things the same way that we have been just because we're used to it. We can't say follow up 3-4 months just because that's what you've always done. We need to more right-size care. That's the idea behind precision medicine or personalized medicine. It's the notion that I need to give you the care at the right time, but that doesn't mean that everybody gets everything all exactly the same. That's not personalized care. That's an algorithm or a cookbook. So the notion that we can help monitor how you're doing out of the office, I think, is incredibly powerful. And in fact, in part, will help address some of the workforce shortages so that we get patients seen at the right time and optimize care.
Mm-hmm. Well, thank you. Yeah, I look forward to continuing to follow the study, this work. It sounds exciting. Exciting. We've heard so much about the importance of personalized care. We don't often get to see it in practice, and now we get to follow you through the years and see how this works. So I'm happy that you've given us this time today. So thank you.
Certainly, it was a pleasure to be able to chat with you about this.